Okay, good evening, everybody. Thank you for joining me and all of us. We have some new faces in the group. Has everyone met Dr. Patel? Yeah? Okay, do you want to stand up and just say hello to everyone?
Yes.
So we're really lucky to have him, and welcome to the team. No one else really is that new here, right? Everyone knows each other. Okay, so...
And a music play.
Oh, yeah.
Are you taking?
Yeah, I'm trying. We'll see how it turns out. I have two recordings. I have the camera there with a microphone, and then I've got Google Meet recording too. Okay, so I'm excited to share with all of you kind of what I've been up to lately. I've gone through a lot of changes in my own practice and kind of started from the ground up and gone back to school really, and have been introducing a lot of new concepts into my practice. And it's been a little over a year now that I've been practicing this way, and I've got a lot of stuff to share, and I'm really excited about it. And so thank you for all being here. Because there's, not just Dr. Patel, but Dr. Noah and Matt, there's a lot of new faces in the group. So I thought it would be useful to go through some of the history of King Ritson. So KRDC, King Ritson Dental Clinic, was born in 1995 when Dr. Albert Camastra and Dr. Brian Rhodes, who each had their own independent practices in the area, joined forces and merged their practices. And these dates might be a little off. Like I worked on getting everything right, and no one really knew. So in 2006, Dr. Adriano DeSanto became a partner and KRDC took over Dr. Adair's practice. I'll show you a map of all that, which was next door. Dr. Stefano Di Pierdomenico became a partner in 2010. In 2018, Dr. Brian Rhodes retired, and Dr. Robert Camastra and I became partners when we bought Dr. Rhodes' practice. So this is an overhead view of King Ritson. The middle, you have the main clinic, and south wing is the little house over here. That was Dr. Adair's clinic. They bought that building in 1998. This building was purchased with this building, but it wasn't originally a dental clinic. They had it rented out, and then they opened up Dental Specialty Associates, also known as DSA. You can actually see that's the sign here, Dental Specialty Associates. And then in 2022, we moved DSA over here, and it became Heritage Dental Specialists. And then this is a map of like the entire complex now. So we have KRDC over here. So there's the three buildings I showed you. And then this is the parking lot. I don't remember the year they bought that. And then this was the old house, which is now Heritage, where we're sitting now. And this is quite a large property actually. And so it extends back into the parking lot. That project we started sometime around 2018. And it took 4 years to get the rezoning done and get everything. Hey, Kelly. In almost 30 years, our team has grown to around 100 team members. At KRDC, we have 12 dentists, 44 clinical staff, 28 admin staff, and 1 denturist. At HDS, we have 6 specialists, 4 assistants, 2 hygienists, and 4 receptionists. This photo is quite dated now, and we should probably take a new team photo one of these days. These are some cool old pictures of this building that we are in now, when it was in its heyday. It didn't look like this when we bought it, but we found these cool old pictures. Do they show up all right on this screen? Yeah. Between 2019 and 2022, we rezoned, restored, remodeled, and expanded this piece of Oshawa history. This is why we decided to name the clinic Heritage Dental Specialists. As part of the rezoning process, required us to designate the building as a heritage building and keep the original house and structure intact. The restoration involved keeping the look and the integrity of the beautiful original structure, as well as adding on a modern addition, building a metaphorical bridge between classic and modern architecture. We are thrilled with how it all turned out. All right, so I thought it would be worthwhile just to show everyone our mission statement. We came up with this a few years ago, and I think it sets the tone for this presentation. So at King Ritson Dental Clinic, our mission is to provide our community with the highest quality dental care in a caring, comfortable environment. So I want everyone to keep that in mind, like throughout this presentation, and we're going to revisit it at the end. All right, this is a fun little video.
A trip to the dentist doesn't have to be a nightmare, especially if your dentist is located at King.
This is from 2002.
A trip to the dentist doesn't have to be a nightmare, especially if your dentist is located at King Ritson Dental Clinic in Oshawa. Joining me today is Dr. Adriano DeSanto, one of several dentists here at this impressive clinic. Hi, Adriano, and welcome to the show.
Hi, Angela. Thank you for having me.
How many dentists are in this location?
Well, we have a team of 7 dentists and a support staff of numerous hygienists, assistants, and receptionists. We also have an on-site dental lab and an on-site specialty office, which offers extended dental care services such as orthodontics, oral surgery, periodontics, and endodontics.
So what are the services that you offer here at this clinic?
Well, we offer comprehensive family dentistry, which includes services such as professional dental cleanings, as well as restorative dentistry and cosmetic dentistry as well.
So how does King Ritson deal with dental emergencies, say if a child falls and breaks their tooth?
Well, we make our best effort to provide same-day emergency care for our patients. Our office is open early mornings for patients to book appointments, evenings, even on weekends. So given that we're open pretty much 7 days a week and the complement of dentists that we have here at the office, we can usually deal with emergencies in a very timely manner.
Oh, great. Now you did mention cosmetic dentistry. Can you elaborate a little on that?
Well, basically, cosmetic dentistry is just a process by which we can correct broken teeth, chipped teeth, discolored teeth, stained teeth, as well. If a patient can't visualize what their smile will look like after the cosmetic procedure, we can use our cosmetic imaging software to give them a simulation of what their smile will look like, so they have an understanding of what the potential outcomes can be given their particular situation. And today you're also going to be meeting Dr. Kathy Johnson, who's going to elaborate a little bit further on some of the other services we have to offer here at King Ritson Dental Clinic.
Great. Thank you very much, Adriano.
Thank you, Angela.
Cosmetic dentistry is very popular nowadays, and with me is dentist Dr. Kathy Johnson to tell me a little bit more about it. Hi, Kathy. Welcome to the show.
Hi, Angela. Nice to meet you.
Does cosmetic dentistry fix all types of damaged teeth?
Well, in extreme circumstances, extreme measures are often necessary. And if a tooth is lost or if it's in very poor shape, then there are a number of options for replacing that tooth. These could include things such as crown and bridges, dentures, full or partial dentures, and implants. Implants are a modern form of tooth replacement, which most closely mimic the natural tooth, and they can last a lifetime.
Now, it's a common known fact people dread coming to the dentist. And how do you minimize that anxiety here at King Ritson?
Well, we like to call them gentle distractions. We have TVs in our reception area and the soothing aquarium. As well, we have a kids area with Xbox, PlayStation 2, and kids DVD channel. We also have TVs in the operatories and CDs with headphones to make the patient's experience as comfortable as possible. We also strive to use modern materials and methods such as air abrasion or drill-less dentistry.
Okay.
And when that is used, there's no need for anesthesia.
Well, you've answered all of my questions, Kathy. And how do you answer your patients' questions?
Well, we try to educate our patients before they undergo treatment.
Okay.
We have a number of methods of doing that, including our intraoral cameras, our computer imaging, our learning channel, and patient DVD, which walks through the steps of each procedure before the procedure is done. We also have brochures available on practically every procedure, as well as take-home instruction sheets for after each procedure.
Joining me now is Dr. Brian Rhodes, dentist here at King & Ritson. Hi, welcome to the show.
Thanks, Angela.
Now, I know you have some new equipment, and what is this here?
This is the CERAC 3D. This is a device that was developed 15 years in Europe. What it allows us to do is to take a three-dimensional picture of someone's tooth, and from that we can mill an exact crown to fit this right here in the office.
Okay, great. So this can be done while the patient is waiting and they can have it the same day?
Exactly. Normally it takes about 2 weeks to fabricate a crown. We can make this with our own milling unit and have it done the same day.
Oh, wonderful. Thank you for showing me around your clinic and being a part of our town. And remember, if you have any questions, their trained staff will be happy to answer them or help you get the answers. To contact King Ritson Dental Clinic, you can call them at 905-579-KING. Remember, if you have any questions, their trained staff will be happy to answer
So since its inception, the reason it's fun video to watch, but it's also like it serves a purpose. Since its inception, King Ritson's dentists have been dedicated to delivering the finest dental treatments to their patients. They continually invest in state-of-the-art materials and technologies, pursue advanced continuing education, and prioritize the professional growth of their teams. King Ritson has a reputation in the Durham region for providing top-tier dental care and exceptional service. In this presentation, I will show you what I've been busy working on for the last year and a half, and hopefully by the end of it, I can convince you that this approach is in keeping with our mission to provide the best that dentistry has to offer in 2024. So just a bit about me, my path. I graduated 2015 from Boston University, and I did my implant surgical training September 2016. And I placed and restored over 500 titanium implants between 2016 and 2023. I've done courses with top clinicians at Spear, Dennis Tarnow and Stephen Chu, Paolo Malo. So I went to all the top courses in titanium implantology. I'll just show you some of my work. Here are some of the complex cases I've worked on over the years. Here's a nice complex aesthetic zone reconstruction I did with Dr. Farawalji. So, you know, we used the Photona laser and did tissue contouring. Dr. Walji did the bone grafting and implants. We prepped the canines to make temporaries. This is the final, but I didn't load the implants, and I did temporaries across the front to maintain all the gingiva, and then finally restored the case. Single central replacements. So I did all these cases, and then full arch fixed titanium implant. So that's one of those is an implant with a zirconia abutment, and that's a natural tooth. Full arch fixed titanium implants, teeth in a day cases, and then these are a couple of cases I did recently. So notice the gingivoplasty. So I'm doing a lot of cases like this now where I will use the laser and contour the tissue and then make immediate temps. So this was in one day. There's the patient's broken old prosthetic. Those are all the teeth that came out. I had done an implant back in December here, so that was still his provisional, and then he broke more. And so this is my implant, and then I put in 2 more. And then the next day, so this is the day of the surgery, and then this is the next day. 5-axis makes me temps the next day. That's what the tissue looked like one day later. So this is flapless surgery. These patients have like very little pain, and there's the provisional in place. And this is another similar case. So I'm creating that tissue contour, and then I'm supporting it with the provisionals. And this is the key to successful cosmetic dentistry is provisionals. You shape your tissue with provisionals and you maintain the tissue. Whatever tissue you create, you can maintain it with the provisionals. If you leave a patient without provisionals, all of that architecture is going to collapse. And then you have to start from scratch when you go to do the final case. So, you know, a lot of patients get complex implant work done. They'll go see a specialist and they get the implants, they get put in an Essex or a flipper or something, and you lose all of that nice tissue anatomy. And so that's what's really cool about doing these cases like this with the provisionals at the same time. And then I'll show you how I managed the risk of doing this. So this is the same kind of case, just a few less teeth. And then I made a night guard right away. So the lab gives me a night guard to insert the next day. And then I want this patient to wear the night guard as much as possible whenever they're not eating. And I make sure that there's absolutely no contact in any of the excursive movements. So his, I had to shorten a lot in order to get the teeth out of occlusion. He's got a super deep bite, and so the temps look beautiful at first, and I made sure he saw them, and then I said, now I have to shorten your temp. But it still does the trick of maintaining the tissue.
And they're not wearing Essex for them.
Yeah, no Essex. Yeah. Okay, so as you can see, I had reached a point where I was performing these procedures in implant dentistry at the highest level and approaching the level of mastery of these treatments. And then you may ask, what happened? So this is me. This is my tooth. And after about a decade of researching natural health, I came to the decision that I wanted my root canal of 27 years removed. The problem was that the treatments that I was providing for my patients, I didn't want for myself. I didn't want metal in my body, and this made it very difficult for me to continue practicing the way I was practicing. So I was all too familiar with the complications of titanium implants. This is a case I recently saw, and it's not my patient originally, and I removed these implants, and I grafted this site and that site. He had some bad inflammation around the implant. I removed the titanium implant, and I put in a zirconia implant same day with an immediate temp. This is a study that was published in 2015 about peri-implantitis and peri-implant mucositis, and the results are, it was a meta-analysis. Oh, it should show the highlights, but it doesn't. It was a meta-analysis, and they found that 43% of the implants in the study had implant perimucositis, and 22% had peri-implantitis. And yet, when our patients are losing teeth and they ask us what's the best treatment available for tooth replacement, we're trained to unequivocally recommend titanium implants to them. In that same discussion, most of us, including me for a long time, failed to disclose that 22 to 43% of those implants will present with chronic inflammation at some point down the road. I now make this part of my informed consent discussion that I have with my patients when discussing tooth replacement options. As we know, peri-implantitis is not easy to treat successfully. Actually, my feeling now is that it's almost impossible to treat successfully. This has been a hot topic in all of the dental journals and magazines for as long as I've been in dentistry. There is a common theme out there that the dental industry should prepare for a tsunami of peri-implantitis. When I started doing implants, my dad said to me that I better learn how to treat peri-implantitis because there's going to be a lot of it. That always stuck with me, and as such, I never advertised or promoted my titanium implant practice because I was never 100% satisfied with the treatment. There are many laser courses out there for treating peri-implantitis, and it was one of the main reasons we bought the Photona laser around 2018. The treatments were never very successful. Most of the implants that either we or Dr. Walji treated with the laser did not improve, and many of those implants we ended up removing. If the problem is the biocompatibility of the material itself, then, which I think is one of the problems with titanium implants, then it doesn't matter which treatments we try to do to save the implants. The inflammation is always going to be there, and the tissue loss will persist. I've borrowed some slides from some of the training I've been doing, so you'll see, if you see like the SDS in here, that's from there. This just shows how titanium particles, which get released from titanium implants over time through wear and tear, trigger inflammation in the body, and also through peri-implantitis therapy. When you go in and you're trying to clean those implants, you're releasing more titanium particles. These particles trigger a local immune response and can also trigger a systemic immune response. That's what this shows here, activating macrophages and inflammatory mediators. And then if you do a Google search, if you type in peri-implantitis tsunami, you get tons of articles. So sometime around 2018, I became aware of these dentists in Europe that were thinking differently and were doing things differently. They called it biological dentistry. One of the core differences was using zirconia ceramic dental implants instead of titanium, reporting that they are more biologically and immunologically compatible. I became immediately interested, and I had planned to pursue further education in this area. The great hysteria of 2020 delayed my plans to pursue this education, but finally in November 2022, I attended a course in Tampa, Florida with Dr. Carl Ulrich Volz. Dr. Volz is the world's leading clinician in ceramic implants, having placed over 20,000 ceramic implants. The dentist at the top there is Dr. Dominic Nischwitz. I'm doing his training courses as well. I'm going to spend 3 days in his clinic in September, and then Dr. Volz is on the bottom there. Both of these podcasts, anyone who, after this lecture, if you're interested in this stuff, these are two of the ones I recommend. So leading up to this point where I went to Tampa, I still had some skepticism about zirconia implants, but after that lecture, I was convinced. And I asked him for advice on my front tooth, and he said to me, if you come to my course in Switzerland, I'll do your tooth for you as part of the course, and you can be the live demo in front of all the dentists. So that sounded pretty good to me. The rest is history. I documented the whole experience, and you can learn about it on my website, and I encourage you to watch my video if you haven't already. So I made a page, and I show this to patients when we're talking. It's like a pretty cool thing when you can sit in the room with a patient, and you're talking about the treatment, and you're like, yeah, I have this, I had this done on me. And I give them the link, and they go watch. Or sometimes I'll show it to them in the room. So here's my implant and final crown. This is a one-piece implant, a single solid piece of monolithic zirconia that can then be prepped and customized for the tooth being replaced. Notice how healthy the gingiva is around the implant. This is the thing I'm blown away with these implants, is when you go to restore it and you see the tissue, it's like perfect. There's no redness, no inflammation. Yeah, I was blown away by how well the tissue responds to the material. Tissue loves zirconia. Now we'll go through a few cases so I can show you how these implants work. This is a very typical case I'm doing now with the removal of a failed root canal tooth, thorough cleaning of the socket, and immediate replacement with a ceramic implant. So this is all in one appointment. I didn't temporize this case. What's that? Oh.
One piece, right? They're asking.
So this is called a two-piece. So that's what I'm going to show you now. So with this company's, there's different ceramic implants. So this is Swiss Dental Solutions. There are one-piece and two-piece ceramic implants. They're both tissue-level implants, and I'm going to go through these concepts. This would have had a cap over top of it to cover the hole, and that I took that picture right after I removed the little screw. And then you cement a post. There's straight posts and angled posts. So because of like the angulation I had to do with the surgery here to follow the roots here, I then use an angled post to correct that. So cement the post in place, and then you prep it. And your prep goes all the way down onto the implant surface. So then it functions like a one-piece implant. The post just adds retention form and resistance form, and the classic prosthodontic principles apply. Other ceramic implant manufacturers, they make a true two-piece. And this is one of the problems that was with zirconia implants at the beginning, is they just basically copied titanium implants, the design, made it in a different material, and then said, here you go. And so they've got true two-piece that are bone-level implants, and I'm going to go through this in a bit. And then you have a classic abutment that screws into the zirconia. These had a lot of failures, and it kind of created a bad name for zirconia. They had these like 20 years ago, and a lot of dentists first got into it and then had a lot of problems and got out of it and said, it's fracture.
So it wasn't very implant.
Well, there's another issue. So with a metal abutment and a metal implant, you get a cold weld. So the connection over time forms a seal. Zirconia on zirconia doesn't do that, and so you have a microbial entry point always. And so a lot of these patients notice like a bad taste or even a bad smell, and it's because it never fully seals. So like the guys in Europe, they remove a lot of these and put in these tissue level. So it's like a totally different material, and you have to treat it that way, right? You can't just copy paste the designs from one material to another, and that was a lot of the problems. So this is the difference. So there you have a two-piece bone level implant, And then this is where a lot of the mechanical failures come, because you have very thin zirconia versus on the tissue level, it's big, solid, thick piece of zirconia. So too much load can cause fractures in this situation here. There's the SDS implant on the left, and then here's some other implant designs on the right. And you can see like where the gap is. Here you have a solid piece of zirconia going through, and then your crown margin would be somewhere at the level of the gingiva or maybe slightly below. In some of these systems, you've got a connection, just like titanium implants, bone level, where there's an interface at the level of the bone. And then even in titanium, that's also one of the reasons why I think there's a lot of peri-implantitis, is because you've got this home for microbes right at the bone level and it's not protected. So let me elaborate on this concept. So in implant dentistry, we have bone level and tissue level. Who understands those concepts? So both of these concepts came from titanium implant dentistry. So many implantologists, like the local periodontist, Dr. Omar Usman, will tell you that the best titanium implant ever made with the least complications is the Straumann tissue level implant. So some of you may remember, do you guys remember this implant, this Straumann implant? So there's still periodontists and stuff out there that says this is the one that has the least complications. And that's a tissue level implant. And the reason it's tissue level is because here's the level of the bone. This is one piece, and then your tissue's here, and the connection is up at the level of the tissue. And that's the same thing here versus a bone level, your connection's at the level of the bone. So the implant collar is polished, and the gingiva can form a weak attachment with the polished surface, and that forms a microbial seal for microbes entering. And then that preserves the integrity of the implant and the surrounding bone. And then in the titanium world now, there's a recognition of this biological problem and the tsunami of peri-implantitis that is created with bone level implants. This is the new Straumann TLX implant. And notice the language that they're using in their marketing. Iconic tissue level, takes into account key biological principles of hard and soft tissue healing, peri-implant health preservation, reduced risk of nesting bacteria, and optimized cleansability with the connection at the soft tissue level. Immediate soft tissue attachment preservation, and I'll show more of that later. So does that kind of illustrate the concept of this tissue level? So this is an immediate implant. Like the old Straumann ones weren't good for immediate implants, and so now they're making this implant that is good for immediate implants, and it's got the connection at the tissue level. So does anyone know, like, what's the problem with a titanium tissue level implant? Aesthetics, yeah. Okay. So is there any questions on this bone level, tissue level concept before I move on? All right. So here's a case that came to me from a local oral surgeon, and it looked really good. I was really happy with the implant placement, and I decided to make some provisionals first so I can start, like, it came in healing abutments, and then I made these provisionals, and I was super happy with them. And then when I went to do the final crowns, these, by the way, are lab processed PMMA provisionals, and that's what I use for all my provisionals. These are like next day ones. So the final, we made custom titanium abutments and zirconia crowns, and I used an opaque cement, so like Panavia opaque, to block out the metal, and it still looked like shit. So, and this patient didn't want me to redo that, and like this one I wish I could have redone. She didn't come back, but the provisional looked way better than the final. So I'll go over these concepts. Looking back, these implants actually are too shallow, and these aren't tissue level implants, they're bone level implants. But for optimal anterior aesthetics with titanium implants, you need your implants deeper. Okay, so this is the concept. So you want your implant to be, so if you measure from where you want your final gingival margin to be, your implant platform should be 3 to 4 millimeters apical to the desired gingival margin. If you have a delayed site, so a healed site, not an immediate, you can place the implant more centrally. And if you have an immediate, then you want to place the implant more palatally, because you'll always get some recession from the buccal, and you need to account for that with your implant placement. Otherwise, if it's too buccal, this recedes and then the threads start to show through. So if you're placing your implant like this, an immediate implant, and you don't place it deep enough, how are you gonna, like if your implant's here, how are you gonna make that space, right? So that's why the implant should be deeper, and then it gives you enough running room, get the optimal outcome prosthetically. So for those who don't place implants, this is still useful information, because you want to communicate with the surgeon, because the surgeons don't always restore implants. So, you know, you might have more knowledge than them in some of these areas, and you say, look, you're placing this implant, please place it with the platform 3 to 4 millimeters apical to the, you know, desired free gingival margin, okay? Yeah, with like, you can't do tissue level implants in the aesthetic zone, right? For obvious reasons. Like, it's biologically favorable. Like, that's what I was hoping to like illustrate to you guys earlier, is that the tissue level implant helps biologically, but then you create an aesthetic problem. So if only there were a solution to this problem. Did the thing go? There we go. A tissue level implant that is white. I've got some of these implants here. So I've got like titanium with some crowns, and then I've got ceramic implants here. So if you guys can pass them around and take a look. And I've got 1 piece and 2 piece of the ceramic in the box. And then this is what I do with patients. I show them the options. I say, these are the materials that we have available. Titanium, we've been doing a long time, and they work really well. There are some issues with them. And now there's ceramic implants that have been around for 20 years. They used to have some issues, but now they've worked the issues out. And this is what I chose for myself. And so this is the conversation I have, and it kind of becomes intuitive. So if you hand a patient 2 implants, a white one and a black one, or a metal one, they're going to say, I want the white one. It's like fillings. It's like, do you want a white filling or do you want a metal filling, right? It's the same kind of thing. So these are, like, there's a pure titanium implant. Then this is a titanium implant with a zirconia abutment. I'm going to show you a case like this in a minute. And then there's a pure zirconia implant. Okay, so your patient comes in. This happens all the time. Like, this happens every week, right? So your patient comes in with this. Can somebody tell me, like, what does this conversation look like with the patient? But this is important. I think it's a good discussion, right? Because these aren't easy. So like, Noah, what does your discussion with this patient look like?
I said that the opportunity to, get that back to where it was is a multi-step process. If the possibility of a root canal, putting a post in there, to then put in a new crown with success not being 100%.
Yeah, with a poor prognosis. Yeah. So it's a lot of time, a lot of money, and for a result that's not necessarily going to work, right? Yeah. Okay. And maybe crown lengthening, right? Like it's never ending what could be done to save these teeth. So in reality, an implant is a much more predictable treatment option, right? Did everyone see the video I made of like how to handle this situation temporarily? So let's say your patient says, okay, I want to do an implant, and but they need something fixed temporarily. Then what I like to do, and I made another video on how to take a good CT scan. So I like to take the CT scan before I put the crown back on, because then those crowns usually have metal in them, and they can cause some scatter in the scan. But just have a look at both of those videos, and that post that I show. I've had patients where it lasts like a year. Like sometimes I'll go to do the implant and I'm trying to get that crown off, and like it's rock solid. So it's a nice way to buy your patients time if they want to do an implant but they need, they're not ready yet or something. Just let them know it's temporary, right? Now the CBCT is important. A lot of you guys take CBCT scans, but sometimes, like when I'm doing an implant, I always take a 5x8 full arch CBCT scan. Sometimes they're too narrow, like the 5x5s, and you can't see enough information, especially if you want to do a surgical guide. So just I cover all of this in this video. So if you are going to take the scan for the patient, just pay attention to all these little things. However, I'm happy to see your patients for consults, and I can do a scan for them. I include it in my fee for the total cost of the implant. So it might save them money. This is the CBCT of this case. Okay, so we're going to plan this case, and we're going to do this case. This patient's got that retroclined anteriors. So it creates a challenge because ideally you want your screw access hole to be in the cingulum. And in this case, that's pretty impossible. So I'll show you how we deal with that. This is the surgery, extraction, immediate implant. That's the drill. Sometimes it's handy to use the pilot drill or one of your drills for your x-ray instead of the pin in these anterior cases. And then look at how deep the implant is, okay? So if we use this as a reference point of where the desired free gingival margin is, then I'm 3 to 4 millimeters deeper than it. Okay, and then I did a immediate scan, okay? So I placed the implant, and then I scanned her with the iTero, and then the lab, I put a healing cap in until the next day. So there's my healing cap. Next day, take off the healing cap, don't need to give any freezing, and then insert the next day temp. So this is something as a restorative dentist you can work together with the surgeon to do. So like if, let's say one of your patients is having an implant with periodontist, you can coordinate and say, hey, I can do an immediate provisional for them. Because most of the specialists aren't going to do it.
For putting in provisional like this, like I see this a lot more and more and more, obviously, as people want.
Yeah.
You know, but what's the downside of this?
The patient has to be aware that, like, you say this is for show. You cannot bite into this tooth. If you're worried that you're not going to be careful, then maybe you shouldn't have this.
Look at the lowers, right? Look how worn.
But exactly. But you just manage the occlusion, right? You keep it, make sure in all the excursions it's out of occlusion, and the patient knows they have to be careful. I haven't had a problem.
Okay.
I do it a lot now, but
They can bite into anything, regardless of their occlusion, right?
yeah, they can't bite into anything. Yeah. So some patients aren't careful and they say, no, I can't trust myself. I don't want to do it. And in that case, you can still do an immediate custom abutment, and then you get the same tissue results. Because all it is a custom abutment is just this with the crown cut off, with this part cut off, but you're still maintaining all that tissue.
Is that much more prevalent to a lot of dentists who place implants?
I don't know. No, most do healing abutments. Yeah, most don't do any of this fancy stuff. But I'm showing you how do you do the next level. Like how do you reach that, like, yeah. And then like the beauty of these is that once you've got the patient in a temporary, they're not in a rush, because the other patients who don't have a tooth, they're like, oh my God, I gotta wait 8 months, 6 months. Like, oh my God, that's so long. But these patients, they've got a tooth. They know they've got to be careful. The first 4 months is where I want to make sure they don't bite into anything. And then like you can wait 6 months, you can wait 8 months, like you can wait till they come back from Florida after the winter. It's like these are so nice to deal with because that temporary makes it such a more easily manageable situation. Okay, so you've done all this work to ensure beautiful tissue healing, and you want to create a nice emergence profile. You've got a smooth provisional. Your gingiva are going to heal and form that nice adhesion to the provisional. And then when you go to restore, you pull off that provisional, you break the seal that's been made to your provisional, and now you have mature tissue, and you're getting ready to cement your final crown. You want to create a sealed barrier because of all those things we talked about before, right? You want the tissue to form an adhesion to the porcelain or to the abutment. So this is what I do when I insert most of my titanium implant crowns, okay? So I give some freezing. I put some topical. I give some freezing in the papilla, and then I take a diamond football burr. I'm very careful not to touch the implant itself, but I create some bleeding of the tissue, and I'm trying to, because it's mature tissue, so I'm trying to reinitiate a healing process to then achieve an adhesion of the tissue to the material again. Here's the crown with a zirconia abutment cemented on a tie base. So this is to avoid that problem I showed you earlier with the anesthetic final result that showed the metal. Now there's some risks with this. These are higher chance of fracture. So you just have to be aware of that than like a full custom titanium abutment. So top left, that's the dynamic screw channel and dynamic driver. Has everyone used that before? Okay, so that's correcting for that issue I told you where, like, because of the retroclined teeth, my access hole, and if you look at my provisional, my access hole did come through the buccal. See my access hole? Okay, but then with that other screw channel, and I'll show you how that works. So this is the screw mentable technique. So I insert the abutment. I don't torque it fully. I torque it just like 10. I want to make sure it's fully seated, but I don't want to torque the screw. Put some Teflon tape in the hole. I do try and paste. I like Verilink because it's got different shades, right? So you can do some fine tuning of the final insertion. And I usually have an appointment booked with the lab in case the patient's got to go back to the lab for some customization and like fine tuning of the aesthetics. And then we do the try-in. Make sure you go to a window because some of the rooms don't have good light, and then you get a mismatched color shade. Yeah. Well, and if you're gonna have them go to the lab, you can't do them at night anyway, right? Because they've got to see them there. Okay, so let's say we're good. Now, sorry, if I need to send them back to the lab, this is nice because I can leave the abutment in place, and then the lab can actually put the crown in and take it out, put it into. They can't do that with a fully screw retained crown, right? You have to send them back to the lab with a healing abutment in place, and then they've got to hold it up. This way they can just insert the crown and take it off, put some, shading on it, stain on it, and then bake it. Okay, so we're happy with the color. We're gonna cement it. I cement it in the mouth. I pull out that piece of tape, and then I can actually remove the whole thing, and then I can clean all the cement. So this is called screw mentable technique, and it combines the advantages of both of cementable and of screw retained. So the issue with cementable is that you can't always get all the cement, right? And then the periodontist gets pissed off at you because, whatever, right? They blame you for the peri-implantitis. So this way you can get the best of both worlds, and then you reinsert it as a screw retained crown. Does that make sense to everybody?
There's a hole in the back of the crown.
Yeah, there's a hole in the crown, and all that. Yeah, and there's cases where you don't. What's that? Not shown? Is that what you said? Yeah. Yeah. So, so what was I going to say? Yeah, there's some cases where you're not doing this, like you're not taking it. Like let's say it's a bridge, you can't take it out, right? Because the path of insertion isn't gonna, like you just can't do it. So don't do it. But in those cases, I still like to have a hole in the back of the crown, because most of the excess cement will come out of that hole. And then you still have some extra Teflon tape in there, and you pull it out and it cleans out the hole, so you don't have cement blocking your hole. So this is the concept of that dynamic driver. All it is a screwdriver that works at an angle. So the normal implant drivers don't work at an angle. They have to go straight in. So like you've got 0 degrees, your screwdriver has to come straight in. This dynamic one, the lab can just re-angle the channel, and then the driver goes in and it can still tighten the screw. So that's, what's that?
Sorry, I said that's it.
Yeah, it's sweet. So these, you just have to be careful, like you can't torque them as much. So you torque them to 20 Newton centimeters maximum. I torqued the screw, I replaced the Teflon tape, then I put clip cap, and the reason for the clip cap is if you ever have to go and retrieve that crown, it's a nightmare if you have to drill through like 7-8 millimeters of composite resin, and you might damage the screw, and so you put your Teflon tape. You could do it with a thicker layer of Teflon tape, and then you want to leave like 3 millimeters for composite resin, and then I put some bond because they'll fall out. It's a stupid reason for your patient to come for an emergency because their filling on their implant crown came out. So just put some bond in there first and then put your filling, and they shouldn't come out after that. And then, is this everything? Yeah, so for a single implant crown, you really don't want it to be an occlusion. And the reason for that is teeth in the PDL have a little bit of give. And so when the patient clenches, the PDL compresses. Implants don't have any give. So if your initial contact is on your implant and the patient clenches, then all that load just goes to the implant. So I like to make sure with shim stock that my shim stock pulls through. If you have bigger cases, like if you've got from the first premolar to the second molar to the first molar, like then it's a little bit different of a game. You need some occlusion. Still a little lighter because you got to be thinking about the compression of the PDL, but you don't want it to be fully out of occlusion. You'll screw up the patient's bite, and some of those patients you'll give them real problems. Okay, here's the final result, and then here's me and the patient. So this is the best that I know how to do a titanium implant to create the best aesthetics, create the best long-term stability with the way I showed you to create some bleeding on the tissue and all of that, okay? Here's the patient. So has everyone seen this guide that I made for the hygienists? So everyone needs to be aware of this and make sure your hygienists are aware of this. You've spent months nurturing this beautiful, healthy, soft tissue and created an environment for healthy attachment to form and create a nice mucosal seal around your abutment. Your patient comes for their hygiene appointment, and what does your hygienist do? Probes, scales, subgingival, flosses, and they disrupt the seal. This is one of the biggest reasons for having complications. Just leave it alone. Instruct patients not to floss below the gum line on their implant. So this is to show, like, this is what's going on underneath. Like if I block the light here, like that's what's going on under the gums of these implants. There's nothing to scale, okay? So after I insert an implant crown, I'll show the patient the x-ray, and then I'll tell them, look, if you floss this, which I tell them, like, if you use a water pick, like, I'd rather use a water pick than floss, especially around implants. But if they're gonna floss, do not pull the floss all the way down. Just go past where the contact is, clean in the area there. You can clean along the tooth behind it and the tooth in front, but do not pull the floss subgingival because it's like a knife and it's just gonna cut the tissue, and now your microbes can go down in there. Yeah.
Because hygienists are taught that they're supposed to probe around implants and all this stuff. So I completely agree with everything you're saying. I understand. But what if a patient comes in and they already have the bone loss around the implant? So now the hygienist has to clean around, like they get stuff stuck, and some of them are older, they can't really get it out themselves. So the hygienists need to know, like, hey, in general, if the implant is healthy, don't touch it. But if it's unhealthy, go for it.
So that's what this sheet is. It's healthy implants. Does it say that there? Yeah, here are some photos of healthy implants. Okay. And then the next one is unhealthy implants. So there's a distinction. Okay. So this has to be cleaned. It's a different situation, right? Yeah. But in general, like, you guys as the dentist should be educated on this. And then your hygienist should ask you, hey, should I scale around this implant or should I leave it, right? Like, so yeah, these handouts should be available to everybody. and then it's a common thing. Like this happened to me recently. A patient came in for an emergency with a gum infection around their implant. And then I go to check when their last hygiene appointment was. And sure enough, without fail, it's like within the last 2 weeks. It's like, yeah, because like they went in there, right? Yeah. So,
This should come up the next hygiene meeting.
yeah. So please be aware of this. We can inadvertently and unintentionally cause a lot of iatrogenic harm to our patients if we are not careful. So with zirconia implants, these same principles apply. Okay, so there's going to be a tissue connect. So these are histological slides, and it shows that the gingiva actually forms an attachment to the zirconia. It's a weak attachment, so you can damage it by doing our dental things. Okay, so same thing, I advise water pick. And it's so important that this connection remains undisrupted. All right, what is the number one concern that I hear from patients and clinicians alike about zirconia implants? Does anybody, what do you guys guess?
Cost,
No?
fracture.
Yeah, are they strong enough? So, are they strong enough, and is there a risk of fracture? So this, I'm going to show you how they test these implants for strength. And they take them through these loading cycles, and they load them like millions of times. And the results show that the ceramic implants are stronger now. They're stronger than titanium implants. And then I'll show you how they test them. So 2 million cycles. Okay, so I'm going to go through a few more cases to show you guys how this system works. So there, in the cases you saw passed around, you may have seen like different shapes of the implant. So there's a bigger one, and it's a big oval shape, and it's really good for molar replacement, and especially immediate molar replacement. I used to like never do immediate implants on molars in titanium, and now I am able to do like 90% immediate implants, and it's because these threads are so aggressive, and it's got such a nice pointed tip that I can get amazing stability in just a few millimeters of bone. So I've got quite a few cases like this now. So you can see I found bone in the interseptal area, and then I used one of these oval shape implants, and you can really see how it just occupies the space that the tooth did. And then I fill the gaps with sticky bone with PRF. So I mix the bone grafting material with their own blood concentrates, and it makes what's called sticky bone. And it's basically you're taking the bone graft material and you're mixing it with their own growth factors, healing factors, stem cells, and it makes for a really nice healing result. And then I'm doing PRF just on just about every case now. So with this little bit of gap that's still left, then I fill it with PRF membranes. And so most of the time I can, these kind of cases, it's no flap. Sometimes you don't even need to suture depending on how the membranes go around. This one I just put a couple sutures just to hold the PRF membranes in place. And this is called the open healing concept. Has anyone heard of the open healing concept? Basically, you all do open healing concept when you extract a tooth without raising a flap. And then you just leave the tissue in the anatomically correct position. And so with these kind of surgeries, you take it to the next level, and you, even if you do flap, you re-approximate the tissue into its correct position, and you fill all the gaps with PRF, and then you end up with more keratinized tissue rather than pulling everything so tightly closed.
Is that the same as just healing by secondary intention?
Well, it's like, it's sort of, but you have all these, like this turns into gum tissue. So it's not just like this slow creep. Like the PRF membranes will convert into new gum tissue. But it's kind of the idea. Yeah. Yeah.
Is the PRF membrane different from your PRF sticky bone? Like, are you using different things now?
You do the same. So there's different tubes. So there's yellow tubes and red tubes, or green and red. The material of the tube is different. So there's plastic and glass. The glass helps the blood clot, and the plastic makes it stay liquid. So it's called liquid PRF, and so it still separates. So you get the band and you get white on the top, red on the bottom, and then you take the liquid and you mix it with the bone, and then over time, after about 30 minutes, it does gel and form like a clot, versus the other ones are the ones you make your membranes with. So yeah. Okay, here's another case, bigger case. So I did.
Do you want me to get that Bristol root thing that I mentioned?
I don't know. It's through here. So this is a failed bridge. There's a bombed out tooth underneath that we extracted, and then I'm cleaning everything out with piezo. I'm using ozone, and then we saved the mesial abutment, and then I placed another implant, and then I would have filled all this with PRF, and then I made a temporary bridge. And so this is the temporary bridge. So the cool thing about these pictures is you can see we've got really nice preservation of anatomy. And this is that concept that I said about when you use provisionals, you can tell the tissue where you want it to heal. And I don't do typically molar provisionals. I did it in this case because like it went all the way to her aesthetic zone. And so this tooth's way out of occlusion, and she's been instructed, like, do not bite on this tooth. It's not the final. It's just for all the zirconia temporaries, the protocol is to actually splint them to the adjacent teeth for the stability of the healing period. So this one, I wouldn't have bonded it to the back one, but I'm relying on that canine to stabilize things. And same thing, like my front tooth that I did, it was bonded to the adjacent teeth, and it just no, yeah, yeah. How do you hold that there?
I taped it.
Oh. So there's the same case, okay? And even like I'm trying to remove all of these foreign objects and everything. So like she's got some like retained root there, and I was actually able to get it out. Like I did my osteotomy here, and then I saw the root and I was able to flick it out. So I'm going to show you a case soon. Like if there's any leftover gutta perca and whatever, like I'm removing all of that. So she's got like bad tetra. I didn't have a temp block to match her teeth, but otherwise it looks really nice. I'm going to show you what I do. Yeah. Okay.
For you younger dentists, you'll see bridges fail.
Yeah, all this old dentistry is failing. Yeah.
That's all my bridge protocols fail. When you're
Yeah.
just when you're telling your patient.
Well, we have the stats. So like this patient, if a patient wants a bridge because their insurance is going to cover it and they're not going to cover it, like we've got the stats on the studies done on the prognosis of bridges when one of the abutment teeth is a root canal tooth. It goes down to like, what is it?
I don't remember, but I've shared it with
Yeah. It goes down to like 60% over 20 years or whatever. Like,
15 years.
yeah. Okay. So this is this just shows the open healing concept. So you can see like the tissues are, this isn't my case. Um, there's this gap here, like it's anatomically correct, and then it gets filled with PRF, and then keratinized tissue then will grow in, and then you get a really nice tissue result.
Julian, do you always suture that papilla area?
But this isn't my case, so like, but it depends. Like it depends if I damaged it. Like if I flapped that open, then yes. If I didn't, then no. Right? Yeah. Okay. So this is cool because this was like a year after I got my tooth done, and then I was able to, what I went and got done in Switzerland, a year later I was able to do in my clinic, which was a nice milestone. And so she's got like lots of inflammation here. So she's got failed endo. The post and crowns come out a bunch of times. She's not my patient. She found me, and so I did the paperclip post, like that I showed you guys in the video before, and I bought her like 3 months, and then she was ready to do the implant. So look at the gutta-percha extrusion there. So I knew that I was going to go in and clean that out. So here's the surgery. So I didn't do like a flap or anything. I did her extraction and implant, immediate implant. There's the implant. You can see I've like packed PRF up in there, and then I prepped the tooth right away. And then I make an immediate provisional. This one I did an Emax because I didn't have the right shade.
What's going on in the first picture?
So that's the apical surgery to get rid of the gutta-percha. Yeah. So I went in. So I went in here, and then with the piezo I cleaned all that out,
You were able to
and then I grafted it.
see it just
Yeah.
It's
Yeah.
amazing how fast you find it. There's a void in the bone.
And then I grafted it. So like I had to make sure I could actually like watch my implant go in, and then I yeah. And then this is 2-week follow-up. So she's already getting reduction of the inflammation there, and the tissue response is really good. And not with titanium. It's like when you do the provisionals on titanium, you don't bond it to the adjacent teeth. These ones, I'm following the protocols of what they've been doing for 10 years in Switzerland. So I think it's just a little safer. Actually, I shouldn't say that. If I promised a patient a provisional and then I don't get good torque on my implant, and then I'm like feeling like, okay, I'm going to still do it for them, then I bond it to the adjacent teeth. So
How do you bond it? Are you using?
so you drill a little,
Also?
there's a video that describes it all, but you drill a little hole in your provisional,
Okay.
like kind of like that. You put some bond in it, and then I use flowable composite. So I just etch and bond the enamel on the adjacent teeth, and then you put flowable. So you put your Duralon, temporary cement in your crown, and then you put your flowable in the holes. You put a little dab of flowable on the teeth, and then you cement the whole thing and cure it. That's why we were late today. We were doing this on 2 of them on someone this afternoon. Okay, so this is what the restorative phase looks like for one of these ceramic implants. So this is how it comes, and then I've used the Photona, and I've done some gingivectomy around it to create an ideal emergence profile. And then I cement my post. Then I prep, and then I use the CEREC, and Louise makes the final crown. So you're making a crown. It's like doing a crown on a tooth, right? So
Now what material is the crown?
Emax, and there's a
Same as your Sarah.
there's a cementation protocol. I'm like, in order for you guys to restore these implants, I've got some training to help you guys with it. Some of the dentists like it. I like CEREC.
Well, you could Sarah.
I don't like that. Do you like it, Louise? Do you like zirconia with CEREC? No. Yeah.
Is there any bonding issues?
There was, but now we have the right protocol.
Okay.
Yeah.
You were having crowns debond from the implants?
Yeah.
Yeah.
So you have to use, there's like Z prime, like zirconia primer.
Yeah.
So I actually use the air abrasion, the Etchmaster on the zirconia, then Z prime, and then you can bond. Yeah. Okay.
Thank you very much.
Okay. Thank you.
Bye, guys.
So if you get into restoring ceramic implants, which I think you should, this is the procedure you will need to master. Oh, Steve, here, stay for 2 seconds. You asked about the sinus lift. Okay, so this sinus lift technique, you use osteotomes, which are little bone tapping. You use a hammer and a little tool, and you keep 1 millimeter of cortical bone intact, so you don't drill all the way into this. The other sinus lift techniques, you go through and then you lift the membrane. This technique, you leave the bone intact, then you use a little tap and you just tap it. It loosens this bone, and then you just put PRF membranes in the hole, and then you can place your implant, and bone will fill, anything underneath the membrane will fill in with the patient's own bone. So you don't need to put bone. I love this technique. And then the implants are super stable because this cortical bone is cortical bone. It's D1 bone. And I've had cases where like all I have is this cortical bone and I have like incredible implant stability.
Therefore, it's no surprise, like here in the molar, if it's the first, it doesn't matter. We are going to use the pellet socket. We don't have to drill in this case. You make sure with the countersink that there's enough space, then you go for the internal sinus lift and put some PRF in the hollow space, and then you're going to screw the balcony implant over there. It's a 4.6 by 11 or by 14, and fill all the other sockets with PRF plugs. And this is a super quick procedure. So after having cleaned the socket, it's about 1 minute until the implant is placed, because you would not have to drill. You take care with the countersink if there's enough space for the tulip extension, and then you do the internal sinus lift and you screw the implant. That's it. Super quick and easy, super high success rate, really nice results.
So this balcony implant you just talked about, it's not available in North America yet, but I use that 6x8 one that I showed you.
When you say balcony, that how it's
Like
regular shape, kind of.
Therefore, it's no surprise.
there, see, like it only goes on one side, so it comes out and it goes out this way, versus like the one I use comes out on both sides. This one's just not available yet.
Yeah, like how do you screw that in between two adjacent teeth? Not hit them?
Oh, it's enough. Like you have space. Sometimes you can shave the implant if you need to. You can like modify the implant and make it narrower as it's going in. Like you just screw it in a bit, and then you can. That's what they did on my tooth. Okay, so 2-piece implant, same procedure I just showed you. Cement the post, contour tissue with Photona, CEREC, and then final crown. And then for any implant crown restorations, whether it's titanium or zirconia, I always try to create nice broad contacts. This one's maybe a little over the top. I think like didn't have a good contour to begin with, but like we did get nice broad contacts, so they're less likely to get food trapping. Okay, this is a really nice case. So this case came from Dr. Mike Sotzis, the orthodontist, and this patient had congenitally missing laterals, and he prepped him with ortho. This is Dr. Cheke's patient, actually, your friend, and so then he came to me. So I did. In this case, I did a surgical guide. I used to do all surgical guides. Now I mostly don't. So I just wanted to be super perfect between, like, it was a really no room for error, so that's why I used a guide. Implants went in, so those are one-piece implants. That's what the one piece looks like. And here's them in position. Just a little flap because I didn't want to lose any tissue. And then same day, prep the implants and make immediate provisionals. So with zirconia, I'm making the provisionals same day because we make them in-house with CEREC. With titanium, it's the next day because the lab needs a day. So there's the implants in place. There's the provisionals, same day as surgery. This is 3 weeks later. You can see like his papilla are starting to fill in, and he didn't have any papilla before. And then this is 4 months later, so the papilla totally filled in. Those are our same temporaries. And so this is called a tissue creep. So on zirconia implants, this is common, and the tissue starts to creep down because it's attaching to the zirconia, and it'll just migrate down. It's pretty crazy. So in this case, we gained soft tissue without any soft tissue grafting. So on the left, you can see like where he started, and then on the right is just 4 months of healing. And then what I did was I actually made another set of temps because I wanted to do some more tissue contouring. So I got the tissues, I got the temps off, Photona to contour the tissue, and then those are my new provisionals made again in-house with CEREC. And like I said, like the temporaries maintain the tissue, right? So this contour that I've now created, I have a provisional on there, and so I can maintain that anatomy. And then this is the final. Yeah, he's kind of like a tough kid, so he like probably didn't let on that it bothered him, but yeah. Okay, so what is the best dental implant material? I think zirconia is the best dental implant material. What is the second best dental implant material? There is no second best. All right. This is how I feel today for all the reasons which I reviewed with you, the biological reasons, the aesthetic reasons, the prosthetic reasons. I truly feel that there's no second best dental implant material. There simply is no other implant that I would want in my body than these zirconia implants which I've shown you today. Jenna, what did you tell me today? We're working together. Jenna did like hundreds of implants with me before she had a baby, and then she came back and I changed everything on her, and she came back and like we're doing nothing the same as I did before she went off. And what did you say? Like, yeah, reluctantly.
Because not all patients
Yeah.
care.
Yeah. Yeah, no, I know. Yeah.
Not all patients care. We all know that, right?
Okay, so these are all the numbers that I want to share with you guys. So we have here on the left 2 titanium options. So titanium restore with CEREC and titanium restore with 5-axis. Dr. Koo and I have been talking about another lab that we might start trying out, and their lab fee is less, so we'll see. But so the cost that I quote the patient for just a titanium implant is $4,500. That doesn't include a provisional if we're making a provisional, but that includes extraction and cone beam. And if I do any grafting, I don't charge them extra. Your restorative fee is $1,975, and that's across the board. That's restoring an implant. So my ceramic fee is $6,000. Because then I'm doing PRF and the implants cost more, and we're doing a lot more things with the ceramic. So if you do if you restore a titanium implant with the CEREC, the lab fee, your fee is $1,975, the lab fee is $550, your net is $1,425. 5-axis lab fees have gone crazy, so they charge $867 for an abutment and crown, and then to mill the model and all this stuff. So that takes your fee down to $1,108.
Competing labs charge.
Yeah, the one we found is $550. Canadian Implant Dental Lab.
That's like, they do that for a reason. So you go there, right?
I don't know.
But they do so much neodent, so it's
Yeah.
Dr. Landsberg is doing neodent, you guys, Chris, you're doing neodent, Drew.
So with zirconia, your fee's the same, but because it's only a crown, it's not an implant crown, the lab fee's a lot lower. So that's in-house CEREC. The lab fee's $350, and you get $100 back for I don't know if you guys know this, but we do a rebate. So if you do a CEREC crown of that $350, then you get a $100 check. Like we do it once or twice a year, and you get a lump sum. So your take home is $1,625 plus $100, and then if you do 5-axis, their single crown fees $357, so your fees $1,618. So I thought that was interesting to show you guys.
But Julie, why is the titanium lab fee $200 more? I know the block is more. The block is $125.
Yeah, because the block is more, and we have to buy the tie base.
Oh, the tie base.
Yeah, yeah.
So the bottom line is you should do CEREC crowns on your implants, right?
Yeah, I do. Well, okay. When I was doing Blue Sky Bio implants, I mastered the CEREC like in-house crowns, and I loved their tie bases were amazing. I don't love the neodent tie bases. I don't really like the crowns and I'm meeting with the neodent guy and some of these dentists end of August, and I'll talk to him about it. But yeah, I'm not a big fan of the crowns.
So then they
But
shouldn't do CEREC crowns.
no, so we're gonna see with neodent, try this other lab and see.
That's not a,
Yeah,
if you're doing a ceramic, then they should.
yeah.
If you do two together, Julian, then you wouldn't do, because you have them done at the lab, right? So you bond them, two side by side,
For what?
for crowns?
Two implants
Two
side by
implant
side.
crowns, if you were doing like a.
Yeah. You can only do with the CEREC. You really only do singles. But with the zirconia, you can do bridges and everything. Yeah.
So just see Julian if you want to learn how to do that.
Yeah.
You definitely don't want to use 5-axis.
I know. I want to get away from it a little bit. Yeah.
So we got to find out something else. But
Well, it's too much. Like your fees, like just under 2,000, and it's almost it's crazy, right? Okay, so and then if the patient wants to save more money, so like my fee's $4,500 for titanium. If the patient wants to save more money, then right now I'm doing titanium implants with Dr. Chris Cheke and Dr. Robert Camastra, and the fee's starting at $3,500 an implant.
for the first so many because they're learning.
Yeah, I'm training
You
them.
guys can offer that to your patients.
No, the temp's in my surgical,
But
Yeah.
if they're doing titanium, what's the temp fee?
like 500. Yeah, but we do that at the surgical phase. So so it goes from 4,500 to 5,000. Yeah. Okay, so criteria for restoring ceramic implants. So restoring ceramic implants is its own set of skills and protocols. It is different than restoring titanium implants, and it is different from restoring natural teeth. If one of your patients is going to come see me for a ceramic implant and you'd like to be the one to restore, I'm going to ask you be trained by me specifically on how to do this well. Before you can restore ceramic implants, you will need to have the proper credentials, education in restoring titanium implants, learn to perform gingivectomy with photona or other laser, learn to restore with CEREC or work with a skilled restorative hygienist. I have some lectures. So I have a ceramic implant prosthetic lecture from Dr. Tobias Steiner, and then sit down with me so you can review the concepts of restoring ceramic implants with you and watch me chairside do it live on a patient. And then to discuss this with your patients, I've made this super easy. I made this article, and it's the evolution of tooth replacement. So I go through like ancient tooth replacement techniques and like George Washington's dentures just for fun. And it's kind of to illustrate to the patient, like, look how lucky we are, like, of how good things have gotten today. And so I go through this is your informed consent, okay? Patients losing a tooth and they want to know what their options are. This covers all their options. And I'll just sit with the patient. I have the booklets here if you guys want to see them. They're on the table over there. And I just sit next to the patient, quickly flip through the book, show them, okay, this doesn't apply to you. You know, like for example, I've got bonded Maryland bridges there, and I'll tell them, you know, this in your case, this isn't an option. Conventional bridge, then titanium implant, and then ceramic implant. And then I've got a link to my experience at the bottom there. And if the patient wants to keep the booklet, they're welcome to. Some of them want it, and that's fine. Some of them don't care, and then we can save it. Oh yeah, we can email them this too. Yeah, yeah. But I have notes. Like I have a notes page in the booklet, so if they're asking about prices or whatever, like you can kind of quote. If you know the numbers I gave you, you can kind of discuss with them. How much is it? Oh, it's 4,500. How much is the ceramic? 6,000. So they'll write on the notes, and yeah.
Told all the dentists here that typically send the memos to refer patients. The first thing I do is email the patient a copy of your evolution and tooth replacement with the fees that you put up there.
Right. Okay.
Then they make the decision.
Yeah.
Or are they coming to you?
Yeah.
Or back to Chris or Bob.
Okay. And then like all my team graciously made it to the meeting tonight, so they're all willing. If you guys see them in the office and you want to ask them something, they're all happy to help you. Okay. Then this, have you all seen this video? So this is explaining all the options for your patients who are losing all their teeth and they want full arch replacement options. So it's 12 minutes. They can watch it at home. Email them the link, whatever, and it goes over all the options with them for that. Okay. Okay. Any questions of anything I've covered thus far? What time is it?
7:23.
Okay.
I have a question.
Yeah.
Do you do ceramic implant? Like, what if somebody needs a like implant supported denture?
So actually, I haven't done this yet, but these these one-piece implants are designed. This here can take a locator. Yeah.
That's cool.
So it's the shape of like what those attachments that go inside the denture, they can snap onto those. Any other question?
No questions, but a comment.
Yeah.
I've seen some periodontists do some lectures in the aesthetic zones and stuff like that, and your stuff's really good. And you're a general dentist, so kudos to you.
Oh, thank you. I'm obsessive. I'm not happy if I finish a case and I get pissed and I lose sleep and all that. Yeah.
Don't do that.
But it's like, okay.
Julian, actually, can I ask one question?
Yeah.
Sorry. Because when you talked about placing the implant more palatal,
Yeah.
when you do it like an immediate
Yeah.
extraction, what if they have a super deep bite and like you're having issues, like if you place it really palatally and they have a deep bite already, like then you end up with having the access hole through the buccal portion, but like how do you manage that occlusion in the final restoration?
Like this treatment planning is full mouth, right? So you have to know you have to be able to diagnose a bite problem, and you might tell the patient like, hey, like you should really have ortho, or you need your bite built up, or what. Like there's risks to like the one patient I showed you earlier where I put the night guard in and I'm doing the excursions. He's got a deep bite and he was a risky case, and I told him, you need your whole bite built up, like, and I said, look, I could do your implants for you, but I think there's a 20% chance that they're going to fail because of your bite. If you're okay with that and you don't hold it against me, then I'll do it.
Get that in writing?
Like Michelle was in the room or whatever. He's a nice, he's a good patient. Like, yeah, I should get it. I'm working on those kind of contracts, but yeah, like there's risks, and you don't mitigate the risk to zero. Like you have to manage the risk.
So basically, there has to be room. If there's not room, we can't do it.
Yeah.
So we have to have ortho, have full mouth rehab.
Yeah. Yeah, you're not magicians, right? We're just, yeah, yeah.
You have no room. You don't do it if you have no room.
Yeah, right.
Sorry,
Or
that's
there's ones that are too narrow. Like I'm seeing one of Noah's patients for a consult, and I'm gonna have that conversation. And be like, look, this isn't ideal. It's really narrow. I might damage one of your other teeth because it's such a narrow space. You really should have ortho to open the space. If you know, and then we'll go from there, right? Yeah. Okay. Couple more topics. I'll try to get through this quick. So this is like this unknown concept in dentistry where they're called cavitations, and there's a few other names for it. So NICO and FDOJ. So NICO is neuralgia-inducing cavitational osteonecrosis, and it's a little bit of an inaccurate name. And then FDOJ is the correct medical term, which is fatty degenerative osteonecrotic jawbone. When you extract a tooth, you're left with a socket, and ideally the body is going to fill that socket with new bone, the patient's own bone. Now the reality is that doesn't always happen optimally. So often the socket doesn't heal completely and new bone doesn't form. The gingiva maybe even the cortical bone will heal over top, but what remains is a cavernous hole within the jawbone that is filled with necrotic tissue, fatty deposits, bacteria, parasites, fungi, and other toxins. These lesions never heal on their own, and they can cause systemic symptoms throughout the body. They require a specific approach to successfully treat, which includes surgical intervention, as well as a nutritional protocol which addresses the underlying nutritional deficiencies that led to the cavitations in the first place. Okay, so you guys might see, I have a funny little thing to show you guys. So you see, like, ignore this, I don't know what this is, might not be a cavitation, but like look here and look here, okay? So these are places where teeth were extracted and the bone never healed completely. So this is in our WhatsApp group. So one of the dentists who's in the room here sent this scan, and he did nothing wrong. He said, hey docs, I have this new patient in the chair and this pan was just taken. 68-year-old patient, can I get your opinions on the bone in this 3.848 area, and I think you mean 3.7, as well as the radiolucency for the, okay, this is the response from the oral surgeon. Hey, doesn't look too suspicious at the 3.8 or 4.8 to be honest. 4.8 is just incomplete healing that can occur sometimes. So then recommended CBCT just in case. So he correctly identified that the incomplete healing had occurred. However, he failed to recognize that this incomplete healing actually represents a pathogenic process and a clinical diagnosis, which I'll show you more about right now. So this quote comes from Professor Brennemark, who was like the godfather of titanium implant dentistry. He said, when I see yellow bone, I cancel the implant surgery. So yellow bone, no implant. So this is well known in surgical dentistry where you drill into the bone and you get fat. That's what it means by yellow. You get fatty deposits, and that's where the tooth was taken out, didn't heal properly. And I'll show you more what this looks like. Okay, so this is what one of these lesions looks like in a tissue sample. And it has been demonstrated that these sites are responsible for the release of inflammatory mediators RANTES and fibroblast growth factor 2, which can contribute to systemic disease.
We will now have a look.
Okay, this is like a quick little video.
For an FDOJ. We will now have a look at the surgical protocol for an FDOJ. First of all, what is an FDOJ? It is a fatty degenerative osteonecrosis of the jawbone. Often we find it in the wisdom tooth area when a wisdom tooth was pulled and the bone couldn't heal correctly. We also find it around root canal treated teeth, infected teeth, and also titanium implants. The problem with the FDOJ is the systemic effects that it has, the negative effects on our systemic health, that I will explain shortly in a second. Here you see a histological picture of an FDOJ. It was from a patient that had a trigeminous neuralgia all his life, suffered a lot. When he died, he asked the doctors to get a probe of this area because he thought something is there and nobody believed him. And when they had a look at it, they could see that the bone was degenerated in this area, and that this was probably the cause for his trigeminous neuralgia. We have a problem with these areas. They have a constant release of inflammatory mediators, and that is RANTES. RANTES is one cytokine that is constantly 24 hours, 7 days a week high in these areas. We know that from analysis of multiplex analysis from laboratories. And what does RANTES? It is a normal cytokine that everybody has in his body, and it goes up if you have a wound, an open wound, for example. It is a chemotactical mediator, so it triggers the immune system to bring lymphocytes, granulocytes to heal this wound. Once the wound is healed, it goes down again. So it is a marker for a wound, for a chronic wound. In this case, when we have a constant release of RANTES, that means the body gets a constant information that we have a wound, and is constantly sending inflammatory markers or healing cells to this area. So the immune system is constantly triggered by this high RANTES. And we know from the medical, from many, over 10,000 medical studies, that higher RANTES levels in the blood are related to diseases like MS, arteriosclerosis, arthroid rheumatitis, also autoimmune diseases, depression, chronic fatigue syndrome, cancer, many diseases, and still the medical field does not know where this higher RANTES level come from. We know, at least in these jawbone areas, and especially for patients who have these diseases, we need to look at these jawbone areas and clean those so that we don't have these constant RANTES levels in these patients. Also, the fibroblast growth factor is elevated. So this is a constant release and causes these diseases that I just named and can promote them. Here you see a surgical protocol of an upper osteonecrosis. You see that you often have a fatty blood or yellow fatty solution that you need to clean. Often there is no good blood support in these areas. Once you've cleaned it out, the blood comes and then you have to look or have to make sure that there are no fatty eyes on this blood anymore. That's a sign that you clean it correctly. It's very important in the tuberous area to really clean everything and also remove the palatal bone, the buccal, and the distal bone so that you don't have a recurrent NICO. We also disinfect the area with ozone, and we supply the area with blood concentrates, PRF, so that we have an accelerated wound healing and a better bone regeneration. And then it's important to make a tight suture to cut out over excessive tissue or use a laser for it, whatever you prefer, and really have a tight gingiva around your last tooth so that you don't have an infiltration or penetration of bacteria around this tooth. And that helps our patient to prevent or take a part in the prevention of these diseases, or also help them when they have these diseases that therapies work better. This is the multiplex analysis of the cytokine profile, and you see that the RANTES level, would be a normal RANTES level in a normal healthy bone. This is the RANTES level they found in over 128 probes of patients. It is 35-fold higher than usually, with over 5,218 picogram. What we also see is that this is elevated. It's the interleukin-1 receptor antagonist. Interleukin-1 is an acute cytokine. That means it induces an acute inflammation with the reaction of an edema, of swelling, of pain, of heating up of the area. So this interleukin-1 is depressed. And that shows us, or that's why patients often don't feel pain. Some have a chronic trigeminous neuralgia, but most patients, it's no acute inflammation, it's a silent chronic inflammation because the acute inflammatory markers are depressed. Also, we have a very low level of interleukin 6 and 8, which are also acute inflammatory markers. And whenever a patient asks you, why don't I have pain, why don't I feel it? Yeah, the acute inflammatory markers are depressed down and the chronic markers are high. It's kind of like a periodontitis. Patients don't feel pain, but their body, their bone resorbs and their teeth get loose, and it's not a painful disease, and it's the same with our FDOJs.
And then this is the guy I'm going to spend a couple days with in his clinic.
How my health changed during cavitation surgery. This is a story I always tell and I never forget because I learned so much being a patient myself. When I finally had the surgery for my cavitations on the right side, I had to laugh during the surgery because my chronic back pain just disappeared. And I was asking my surgeon, is this even possible? And yes, it was, because it never came back. Before the surgery, I was already having shaky hands and I felt like I had Parkinson's every morning, like I was drinking 3 cups of strong coffee. This nervousness also went away for good after surgery. My skin was still bad though. About 5 days after my second surgery, the left side, my skin issues started to disappear, and within the next 2 weeks I had developed the skin I was always dreaming of, and my whole back pain, which was actually referred pain from the chronic inflammation in my small intestine, which is always connected to the wisdom teeth cavitations, this was also gone.
It's most commonly in the wisdom tooth area where you get these incomplete healing. And it's for several reasons, like it's a traumatic surgery. So it's like versus just having one extraction, like the wisdom tooth surgery is pretty traumatic. And the patients aren't coached to do anything to prepare their body for the surgery. So like, and then we're going to talk about vitamin D and stuff like that. Like, and there's nutritional things that you can, like check boxes you can hit, and we're all deficient because of our messed up food system and everything, right? So, yeah. So this is a meridian chart, tooth meridian chart. So that on the left, and it's scientifically proven these connections between the teeth and different areas of your body. So it was done, like the link to the studies here, and there's some more info on the bottom, and they used electroacupuncture and mapped out the whole body and where the teeth are connected. So that's why you can have symptoms somewhere else in your body related to a tooth infection. And I don't know if you guys got a chance to watch the video I sent of my patient who had this crazy healing after we dealt with her oral infection, which, like, I don't know exactly why that happened, but the connection's there, right? So can you explain how to use it a little bit? So like if I'm having a consult with a patient who's interested in their health and all these things, then we'll sit down, I'll print out one of these charts and I'll print out their pan, and then I'll circle the teeth like that could be potentially connected. So then I'll say, like, okay, I'm circling this tooth for you, and then you look down this list and tell me if, like, do you have any symptoms in any of these areas, right? And then you can look at the wisdom tooth areas, like if they had their wisdom teeth out, then you can circle the wisdom teeth and look for any symptoms there.
So for example, that pan he showed that had those cavitations, you
those,
say to those patients, do you have any
yeah,
issues here?
yeah, thanks.
It works, and she was surprised.
So this is the Carol that you guys saw, so we can save some time.
So did that one show her pan to her problems?
I don't know specifically in her case, yeah. So this is her other side. So her symptoms cleared up after we did her right side, and then we went and did her left side. So does this one? Oh no, that's not a video. So there's me planting the implants, and then do you see this here? And then I went in there, I removed the cortical plate, and look at all this fat. So this yellow stuff, that's all fatty deposit just stuck to the bottom of the cortical plate. And then this was full of fat, just clean it out, and it's a giant hole in her mandible. Like, I didn't remove bone. There's no bone. So
Incomplete healing when they're all sort of
what's that?
incomplete healing.
Yeah, incomplete healing.
What'd you put in there?
So then you once it's cleaned out, you start to see the blood is clean. Like you have oil in the blood, like you could dip your bread in it, like at an Italian restaurant, and then it goes clean, and everyone's done eating, right? Yeah. Yeah. And then it bleeds clean, like clean blood. And you can look for this when you do your extractions too. You extracted a bad tooth, and like in my experience and what assistants that work with me from working with other dentists elsewhere and stuff, they tell me that the extraction ends when the tooth comes out. But like when that tooth comes out, you've got so much more work to do to clean out the socket. And you can look for you want really nice bleeding, like clean blood, especially those super infected teeth. So then I keep cleaning until the blood's clean, and then I treat the cavitation with ozone gas, and then I fill it with PRF membranes. I stuff PRF membranes in there, and then suture it closed. And the PRF membranes have metronidazole. Is that what we put? Yeah. In the membrane, so you've got antibiotic local in there, and then I'm doing IV antibiotics lately, and the reason for that is you bypass the gut. So we know how antibiotics can kind of wipe out someone's healthy gut bacteria. So if you give them the antibiotic IV, you bypass the gut, and then you save them that yeah. So I've been doing that.
Julie, do you use, what if the patient wants the implant like later, like they only want the extraction now? Would you still use clean it out, ozone, and then how would you like fill that void up? Would you just put PRF, or would you just put grafting material?
Yeah, so I have a procedure now that I call a biological tooth extraction. So I still use PRF. I still get them, like, we're talking ideal here, right? So if I needed a tooth extracted, I would get my vitamin D tested. I would make sure my vitamin D is between 150 and 200. And then your body's, and there's some other supplements you can take, and nutritional things you can do, and foods you can cut out that are pro-inflammatory. And prepare your body. Like, we don't prepare our bodies for surgery, we just go for surgery. But there's so many things you can do to make your outcome better, right? So you heal better, you have less complications. So that's the approach. So ideal situation, patient wants the best possible thing for them. It's the biological tooth extraction. You prepare your body beforehand. Then you do PRF. You use something, not just a curette to clean out if it's badly infected, you need to use something more to clean out the infection, right? So I use the piezo, and then I use ozone, and then you can do sticky bone. Like if you want an implant, the same concepts still apply of you'll lose less bone if you do the bone graft, but I'll show you like the bone grafts where you just clean out the socket and put some bone material in there. Those ones don't always heal. Like and you know, you never know why. You go to place the implant and you're scooping. Have you had that, Maru? Yeah. Yeah. Some yes, some no, right? Yeah. And so this has been an evolution. Like I did a lot of bone grafts. And I was telling all the patients, yeah, you need a socket pressure. And then you go to place the implant and you just have like sand in there and you're scooping it out. And they didn't convert the bone into their own bone. Not all of them, but it's like 60% success rate. Yes.
So you have a biological socket preservation kind of protocol?
Yes. Yeah. So why does this happen, this cavitation thing? So nutritional deficiency results in poor healing. In order to build new healthy bone, the body needs the right building blocks to be able to do this properly. These building blocks come in the form of vitamins, minerals, and proteins, aka micronutrients and macronutrients. Examples: vitamin D3, K2, vitamin C, magnesium, zinc, omega-3, and more. Other factors: inadequate cleaning of the socket. So if you don't clean the socket out properly, they can end up with one of those incomplete healings, right? PDL fibers you have to remove, any granulation tissue left over after the extraction. I find patients that are like poorly hydrated, like they don't have any bleeding, you extract the tooth and there's no bleeding, they don't heal well. Like if they don't have good blood flow, they're not going to heal well. It's the only way the body delivers nutrients to the site is with blood, right? So hydration is an important part of my bone healing protocol. And it's also so I can get good PRF membranes, but it's also so they just have better blood flow. And then their neurological state. If the patient's in a fight or flight state, then they're not going to heal as well. And I tell them this: people do too much after they have dental surgery. They go back to work. They go work out. They always say, "Can I go to the gym?" Whatever. You shouldn't. You just had a surgery, and your body needs to allocate resources to heal. And if you put yourself in a stressful state, then you are going to have compromised healing, right? So there's a lot of factors. This chart shows through our industrial farming practices how the mineral content of our food has decreased over the last 100 years. So like it shows different minerals here. So, phosphorus, selenium, copper, magnesium. And then each different farming technique. So like fertilizers and pesticides and industrial chemicals. And then we have GMOs. And every single time you destroy the quality of the food and the soil. And so you'll see, and this is like why one of my passions is promoting local regenerative and organic farms, growing and raising food the right way and the healthy way. But you'll hear an apple from 1950 had you have to eat 50 apples to get the same amount of mineral. Like you guys ever hear this kind of stuff? So that's what's gone on with our food, and so we don't heal as well. Like probably people that ate kind of a more ancestral kind of diet didn't have, probably in India they don't have the cavitation problem. Yeah. So here's like more charts of all the nutrients involved in healthy bone healing. So the ones I mentioned, then there's vitamin A, B vitamins, boron, all this stuff. This chart provides a good overview of the whole cascade of events and the role of micronutrients involved in healthy bone metabolism. This, Dr. Volz said this is his most expensive slide because he paid different scientists to collaborate on this slide. So he said he spent 5,000 euros on this slide. And then this is kind of interesting from two-time Nobel Prize winning scientists. You can trace every sickness, every disease, and every ailment to a mineral deficiency. This is my leading hypothesis personally on why people who have immaculate oral hygiene and eat a healthy diet still get tooth decay. Okay, you know those patients like, oh, I floss every day, and they their teeth are immaculate, but they still get cavities. A lot of patients say they have soft teeth. I think a lot of these patients are mineral deficient. Teeth are highly mineralized structures, and when the body is depleted of minerals, the teeth demineralize. So that's what we learn in school is teeth go through mineralization and remineralization and demineralization. So someone who's got this soft teeth problem is on that, they're too far on the scale of demineralization, right? This is another interesting. Minerals are the principal energy producing components of the human body. It is the relationships between the minerals in your tissues that help determine your physical and emotional destiny. Through an understanding and control of these basic laws of human energy, you can vastly increase the intensity and quality of your life. These are a couple of my cases that demonstrate this concept. So this tooth was extracted in May 2023. Does this show? Yeah, so this is the CBCT 5 months later. So you can see, like, if you can see this, like, you know that you don't have good bone in there, right? And in this case, you can even on, oh, there it went, okay. So you want like this, like you want the bone to look like this or like this, right? Like that tells you have nice, dense quality bone in there. In this case, you could see the rendering, the 3D rendering. That's just that 3D image. You can see the defects on that 3D because the bone density is so much lower. Oh, nice landing.
Can that stay there? Do you want me to try again? Yeah, I literally mentioned that too. I've only had to do that one time, and it did stay up.
I did the implant. Yeah, I cleaned it out. Yeah, like that's what this case here. I had this one shows it really well. So if you did your extraction and your bone graft, and then you see the patient months later, you see how it healed. Do you see this like crappy quality tissue here? That tells you that the bone is crappy underneath. So this case, the extraction was done July 2023, and then 4 months later we took the 3D scan, and then you can see, like if you look, so see the bone, you can see the bone graft material. So I knew going into this surgery that I was going to be cleaning all of that out. See, this is the surgery, all right? So I basically treated it like an immediate, right? So open it up, clean out all the bone that didn't heal, and then I secured the implant just in the cortical bone. So the cortical bone I did one of those internal sinus lifts, the cortical bone of the sinus. I got all the stability, and then I actually did an immediate temp on this one. Here's another one, March 2023, conventional socket graft. This was before I was doing the improved like biological extraction. And does this do it? Yeah. Okay, and then same thing. So this is 4 months later. So this is supposed to have healed and be ready for an implant. See the crappy tissue there? So I knew, right? So you can start to see patterns, and like you know that there's not going to be good bone in there. And I still did the implant, cleaned it. So there's the socket, like cleaned it all back out, and then I secured the implant in the floor of the sinus, and then I did sticky bone around, and then you can see I got some better bone healing there. And I got him on vitamin D. I got him on all, like he wasn't on it the first time around, and then the second time he healed better.
We've had implants that were failing, tested vitamin D, get them on vitamin D, and the implants heal.
Yeah, and mobile.
Yeah.
The implant was mobile.
And that was Landsberg's work. Some of it was Landsberg.
Yeah, one was mine, one was Landsberg. Yeah. I was getting ready to take the implant out. I booked the patient for the surgery to take the implant out and put in a new implant, and I had her start taking vitamin D so that she would heal better this time. And I go to take the implant out, and it's integrated. Yeah, I have a protocol there. So I have a protocol. Over there, one of my sheets is bone healing protocol, and it has, depending on where they test, then it tells them how much to take. So if you're not too low, you take 5,000 a day. If you're really low, you take 10,000 a day. Yeah.
I had perio patients that were perfect, and 2 years later come back to perio was a disaster, and then check the vitamin D, super low. Really? Yeah. So those people
It's all, yeah.
Go down. It's shocking.
And we're gonna go over this quick. I'm almost done, but thanks for, you guys are all great tonight. So, you can't just take vitamin D by itself. So they work together. You need, what's that? No, but you want to take it with vitamin K2, with magnesium. They all work synergistically. So you can actually have some toxicity from too much vitamin D if you, yeah. So, okay, so more resources on this cavitation topic. So there's this organization that I'll tell you more about after. IAOMT, they did a position paper on these jawbone. This is, believe it or not, this is like a controversial topic in dentistry, these cavitations, of whether it's a thing or not. And it's like dentists have gotten in trouble for treating them because it's not standard of care or whatever. So it's an area where there's more knowledge coming about, and probably in the next few years we'll start to see it become recognized by the boards and all, and then people acknowledge, yeah, there is a problem there. So there's this position paper from the IAOMT. There's this Dr. Johann Lechner who wrote a textbook on this whole topic, and I have his lectures. I have a couple of his lectures available. If anyone's interested, I can give them to you. So what can we as dentists do about this? How can we help our patients heal better? I hope that I've convinced you that that it is not enough to simply perform a conventional socket preservation and expect your patient to grow new healthy bone in the socket. Some may, but the failure rate will be high, and this complicates the eventual implant surgery substantially. In the worst cases, implant placement might not even be possible without an additional surgery to correct the defect and reinitiate the bone healing process. What can we as dentists do about this? Yeah, how can we help our patients heal better? So this is the bone healing protocol that we were talking about, okay? It's a series of nutritional and lifestyle protocols to follow that will give the patient's body the right micro and macronutrients needed for optimal healing, as well as reduce overall stress and inflammation that could impact their healing ability. The patient starts at least 2 weeks before the surgery, but ideally 1 month before, to prepare their body for surgery. This pays huge dividends in the long run in how well they heal.
Most of our family takes all this stuff all the time.
Yeah, that's what I was going to ask. Is this stuff you'd recommend taking just for general health purposes?
Yeah, like we can talk. I've got another resource there that's like this. So bone healing protocol, everyone grab a copy and review. Yeah, they're like, they should be 150, they're 20. Yeah.
And we had a male,
Yeah.
and I think he was the lowest so far. He was like 37. So
Yeah.
optimal's 150.
Yeah.
Living in Canada, if you don't take it, you're low.
So I have this booklet here that I give to, this is a nutritional, like 15-page thing that goes over a lot of this stuff. Yeah. Okay. For minerals, there's ways you can get more mineral, because like I said, the soils are depleted in minerals. There's some ways you can get more minerals into your diet. So there's some good sea salts that have trace minerals in them. So that one on the left is called Celtic sea salt, and it's got like 40 some different trace minerals in it. This is like a shilajit. Do you guys know what the Indians know what that is, right? Yeah. So it's like yeah.
Indians know everything.
They know everything. Yeah. Anyway. What's your mom's what?
My mom's name is Ajit.
Oh. And then also for like rebuilding new tissue, it's really important that the patients are getting enough protein. So someone going through dental surgery, and I have this, have you guys seen my post-op form that's on, it's like post-op on one side and food recommendations on the other side. Make sure you guys use that for all your patients. And Kristen, you have it, right? You can make sure that, yeah. So they need to be getting 2 grams per kilogram of lean body mass per day of protein. So it's a bit of a calculation, but it's a lot. But you're rebuilding tissue. Proteins are the building blocks. That's how you're going to rebuild tissue. Collagen's really good. There's some interesting like info here. We lose collagen as, you know how people's skin gets thin as they age? Like you just get this thin skin. By the age of 20, we start to lose collagen from our skin at the rate of 1% per year. So by 50 years old, we've lost 25% of our skin's collagen. By 75, we've lost 50% of our skin's collagen. Yeah, so this is like the supplements. So in the US and in Europe, they use nanograms per milliliter. So you'll see different measurements, but our patients, it's nanomoles per liter. So it'll come back, they should be 150 to 200, that's the ideal range. It's 60 to 80 nanograms per milliliter. So you'll just be aware of that. And then the big five. So the big five supplements are D3, K2, magnesium, vitamin C, omega-3. And the implant company makes them, and it's like to help the patients heal from the surgeries. And they come in, I've got them over there on the table. They come in these cool little packs, and they're these little beads, so you don't have to swallow, a bunch of big, huge pills. They're a really nice little thing. They just take one packet a day for 2 months. And I have these available for all my patients. And then there's vitamin D drops. I brought some samples there too. These are the beads that are inside the packet. So they're tiny, and they've got multi-layered coatings of the different vitamins, and it's slow release. So like you take a pill that just has, it bursts in your stomach and it just releases everything at once. These release slowly over 24 hours, so the absorption is better. Yeah.
And showed us, and she was going to have to take something like 20 pills a day to make up one of those.
Yeah.
So she returned everything and bought the pellets.
Okay, so we'll just quickly go through. I'll go really quick. Vitamin D, there's all these studies that show how vitamin D impacts bone healing. So vitamin D activates osteoblasts, inhibits osteoclasts, and thus leads to a healthier bone, to more bone volume, as well as to a better mineralization. Vitamin D shows a positive influence on periodontitis, like my dad said, on MIH, molar incisor hypomineralization. So we're talking about this mineralization issue of not enough minerals. So vitamin D actually helps your body process minerals properly and deposit minerals into your bones and teeth versus having them be leached out of your bones and teeth. And these are pregnancy studies. So vitamin D administration during pregnancy has a very positive effect on the later dental health of the child. So this gets into how do you prevent all these dental problems that we see everywhere, and it starts in the womb, right? It's the health of the mother and the nutritional health of the mother before she has a baby. So, and then vitamin K2 shows a very positive influence on the mineralization of the bone. It also has positive effect against osteoporosis and arteriosclerosis. MK7 is the most bioavailable form of vitamin K2, so you'll see the supplements D3 MK7. That's what that is. Sorry. So furthermore, vitamin K2, MK7 has a positive influence on life expectancy, general fracture risk, and against soft tissue calcification, arteriosclerosis, caries, and endocrine function. All right, so this just a review. So D3 activates osteoblasts, inhibits osteoclasts, strengthens the immune system. Remember that whole stuff about people with D3 deficiency had worse COVID outcomes, and there was like one really easy thing people could have done is just have their vitamin D better, and they would have had better, reaction to the cold. So vitamin D, K2 reduces intravascular calcium, increases calcium in the bone. Magnesium. Magnesium positively influences bone density, muscle, gum, and tooth health, and the aging process in general. So this is why I say it's important to take magnesium and K2 with D3, because they all work together, right, in this process. So if you're magnesium deficient, but you're taking a lot of D3, it's not really helping you, because they're called cofactors. All right, we'll rush through all this. Vitamin C has anti-cancer effects, helps improve quality of life, and it helps with bones. So vitamin C activates osteoblasts, inhibits osteoclasts, improves bone mineralization and healing after implantations and bone augmentations. Also, the periodontal situation is improved. a lot of these surgeons, and I'm going to start doing this, they do high dose vitamin C IV at the time of the surgery. Okay. Anyway, I have all this info available if you guys want. Omega-3. And there's studies for all this stuff too. So omega-3 helps fight many chronic diseases, promotes new bone formation, contributes to dental health, and reduces inflammatory process. The whole thing is, we used to get a balance of omega-3 and omega-6, but now we get way too much omega-6 and the balance is all off. And so that's why you need to supplement with omega-3. Or if you have an amazing diet, if you like lots of fish and stuff like that, you might be okay. But yeah, it's hard. It's super hard these days to like eat properly. So we just get way too much omega-6, and then it's very inflammatory. And so omega-3 has an anti-inflammatory effect. Okay. So this is kind of like this whole bringing all the concept together, okay? So you get patients like this, and the mouth has been treated like a construction site. You've got all these screws and pins and you know, posts and all these things, and we fail to get to the bottom of why they ended up with these problems in the first place. Was it a nutritional deficiency? Was there maybe an underlying airway problem which made them mouth breathers, which accelerated their tooth decay? This is one of our patients, and he really embodies this idea of the mouth as a construction site. This is a family friend. Okay, like this is just crazy. He's got 11 root canals. Yeah. Okay, so I'm not going to make, so he was recently diagnosed with prostate cancer, and he's going through cancer treatment. I'm not going to make any claims here, but is it possible that his oral condition contributed to his systemic disease, in this case cancer? And I think yes. This is the same patient. So you take your routine PA and you see this. So tell me how this conversation would go with this patient. Would you recommend retreat, extraction, and what about the 4-6? No, what is this conversation? I want to know what is this, because I think a lot of us still send patients for retreats. This is why I'm showing this slide. Because you have the conversation with the patient and they go, I don't want to lose a tooth, what can I do? And you say, oh, well, I can send you for a retreat. Am I wrong? Or?
No, it's definitely easier.
Yeah.
Dagger sometimes says no to these though.
Yeah, he's starting more.
He doesn't want to deal with the
Yeah.
post.
Yeah. Yeah, but look at those teeth. So this is what it looked like underneath the crowns. Can you possibly turn either of these unhealthy teeth into healthy teeth? And like through endodontics, like do you think a perfectly performed retreat can make either of those teeth a healthy tooth? No. I don't think so. And in my opinion, extraction is the only sound treatment option in this case. And sorry, to go back, how often do you see a tooth like the 4-6? Like, sure, you can see a little bit of inflammation here, but like, I used to always go and like, yeah, that tooth's fine. Your tooth's fine, right? But yeah, but it's black. That one's black. This one was all like soft, but this one's, the whole thing's black. And so we did the biological extractions. He healed amazing. I wish I took a picture of the healing. There's the open healing concept. Okay, see how I've left like the sockets intact and then sutured in the PRF membranes. So sticky bone inside. He wants implants later, and then PRF membranes on top. These are the teeth. So like, how are you going to make that a healthy tooth with a retreat? So I show this to patients now. So this is on my page of me getting my tooth done, of like, And so when you have these conversations, like, I think, hey, this is what your tooth is going to look like when I take it out. Like, do you want this in your body?
And just to go further, they don't have to have implants. Partial
Right.
are a good
Yeah.
option. You want to get healthy tissue.
Okay, here's another one. This patient's a dental hygienist, and she was Megna's friend, our hygienist Megna, and she found me, and so we've been fixing her mouth. So the 4-6 I extracted and grafted, and then we got ready to do the implants. So what about this tooth? What do you guys think of this tooth? Looks fine, right? Looks pretty good. Okay. That's the 5. No, they're on. I left them on. I just took the tooth. Yeah, it's black.
No, the crown's open. I must have lifted it off.
What do you mean? No, this is tooth. This is the margin.
It is?
Yeah, yeah,
Wow.
yeah.
It's the reflection of the blue.
Yeah.
Makes it look, yeah.
Yeah, this is you mean the PFM. But do you want that in your body? Or would you want this left in your body? Okay, so there's this dentist, this biological dentist who he sends every root canal tooth he extracts for, what do you call it? Profiling, like they test it for microbes, and he shares the results, and they always come back like full of pathogens. So his name's Dr. Kelly Blodgett. He's pretty prominent online. You can follow his Instagram. And this is a good podcast to listen to also. Okay, so this is that same patient I showed you where I took out the 3 teeth, and then I did the cavitation in the back. All right, so that was that surgery. And then we did the other side. So I did cavitation here, extraction. So see that other tooth she had there. So that was one day. I just spent the full day with the patient, did her whole lower, 4 implants, 3 extractions, 2 cavitation. And then at some point in the future, we're going to do her upper arch. Metals. So in dentistry, we have a history of using a lot of metals, from amalgam fillings to PFM crowns to gold inlays, onlays, crowns, even titanium implants. All metals carry with them the problem of corrosion. There's this concept in physics called galvanic corrosion, and so it occurs when 2 or more dental prosthetic devices with dissimilar alloys, so 2 different metals connected in solution, which is the saliva, come into contact with subjected oral liquids like saliva. The difference between the corrosive potentials results in a flow of electric current between them, and a galvanic cell is formed and causes the increasing corrosion rate of the anode and enhancing the amount of ion released. The galvanic current passes not only through the metal connections, but also through the tissues, which may cause pain. So you've all seen this when you see like a filling like this, and it's like black like this. That's corroded. Okay, so this happens because we've got 2 different metals in the mouth, and it's connected with saliva. So you create a cell, and electrons flow from one to the other, and metals dissociate, and then the patient is getting those metals, they ingest the metals, right? And okay, so this is one of my patients from last week. It's not the best picture, but you can clearly see the corrosion of the metals. There are even BPA-free composites now, which I'm providing for my patients, and we can make available to everybody. There's this smart metal removal procedure, especially amalgam. It's very important to protect the patient and ourselves from the material being removed and the mercury gas vapors being released. We've all seen how gross it is when you remove an amalgam and there is that metal dust all over the patient's cheek and tongue. It's not very nice, and you really don't want to be swallowing that stuff. Our patients deserve better. You always have to think of how would you like to be treated if you were the patient. So this is like over the top a little bit. You cover everything, and like because the patients come looking for this, right? So they want you to, they're like paranoid and everything, right? So anyway, I think it's nice to use a rubber dam to remove amalgams just because of that dust that goes everywhere. And there are patients who are looking for people to do specifically this technique, and you get certified in it and everything. So just wrapping up here. So biological dentistry, a biological dentist looks beyond the mouth when considering the best treatment options for their patients. Biological dentistry is the marriage between oral medicine and functional medicine, and considers how the state of the mouth and the various treatment options available may impact the overall well-being of the patient. As a biological dentist, you no longer have to sit and watch your patient's condition deteriorate as the years go on. Instead, you can help them with the remediation of oral toxicity and infection, and ultimately help them along their journey to optimal health. So that's my I wrote that. That's kind of my definition of what biological energy dentistry is. And to go back to the very start of this long presentation, I hope I've given you lots to think about. Since the early days, CareDC has predicated itself on bringing the very best that dentistry has to offer to our patients. We have been at the forefront of many of the major paradigm shifts in dentistry. In 2002, we became one of the first clinics in Canada to implement CEREC CAD/CAM technology and same-day indirect dentistry. In 2012, we adopted cone beam CT technology and computer-guided surgery, which fundamentally improved our diagnostic abilities and surgical outcomes. And today in 2024, I believe we are at the forefront of the next major paradigm shift in dentistry, which is ceramic implantology and biological dentistry. I invite all of you to join me on this journey in my endless pursuit to provide our patients with the highest level of care, which is in keeping with our mission statement. Okay, to provide our community with the highest quality dental care in a caring, comfortable environment. So this is kind of where I'm going with this. So I'm starting a new practice called Terrain Dental Wellness, and all of you can operate under this, and it's the biological dentistry arm of King Ritson Dental Clinic. The reason is there's patients looking for this, so I want to create an online presence so that it makes it easy for people to find us, and we talk about these things we're offering. People are driving far now to come see me. I had a patient fly already twice. She's coming a third time from Nova Scotia. I've got people driving from Waterloo and London and Burlington, someone from Rochester. So the patients are out there and waiting. As we further our education and develop our biological dental practice, new patients and existing patients will be given the opportunity to receive a different level of care, one that includes all of the comprehensive dental services that we currently offer, but also with particular focus in other areas that contribute to dental health and overall health, such as nutrition, airway health. This would involve a more comprehensive health evaluation in our intake process, as well as longer consultations with team members trained in nutrition and prevention of oral disease. The treatment philosophy will follow the biological principles outlined in this presentation. I certainly need your help in this area. I have many patients who are finding me for the surgeries that I'm doing, but they're also looking for a general dentist to see them and their families. And they know other people who are looking as well. I simply can't handle the workload, and in my practice, I'm moving away from general dentistry and routine dentistry, and I'm focusing more on surgery and full mouth rehabilitation. There are massive opportunities available for those of you who choose to go down this path. The patients are waiting. So this podcast just came out last night. So this is my mentor, Dominic Nischwitz. He just went on the Gary Brecka podcast, which many of you might know. And this came out yesterday, and then he messaged us, a group of us, this morning, and he's gotten flooded with people contacting him because he talks about the dentists he's trained, and they're all messaging him, where do I find your directory of dentists? Where do I? So it's like the patients are looking for. Oh. So like information is, the world's changed and information's traveling differently. So with internet and podcasts especially, like these things just, it's changed the game. Yeah, exactly. What's that? Yeah, so conventional dentistry versus biological dentistry. So I like to refer to some of what we do as commodity dentistry. And by that I mean an implant is a commodity. Patient comes to you, oh, how much for an implant? Oh, $4,500. Oh, the other place is doing it for $3,500. How come I'm going to go? Like, it's like you're dealing in commodities. They don't value anything special about extra that you're doing. It's just an implant is an implant, a crown is a crown. Okay. We compete on price. We compete on convenience. We got to be open, and accommodate their schedules, everything, and everything's very insurance driven. Where is this going? We've seen like Canada, the landscape of dentistry change in Canada. It's like been crazy corporate dentistry. Maybe some of you have worked in some of those Dental Corp or some of these others. And now we've got government funded dentistry coming in with the CDCP. Okay, so this is the direction that's going. I don't know what's going to happen with the government funding. They might fail, whatever. But this other side, the patients are health focused. They take responsibility for their own health. They're willing to travel long distances to see you and come on your time. So you tell them when you're available and that's when they come. And patients value the treatment you provide. And in this current climate of corporate dentistry and insurance-driven dentistry, biological dentistry is a great way to differentiate from all the other dental offices out there competing for patients. This is the IOMT. This is the dental organization for biological dentistry. Okay, we don't need to go through that. You can visit their website and they've got a lot of good content. They have a conference in September in DC. I might go to this one next March in Utah. So if anyone wants to go, we can go together to that. And then at their conventions, they've got a full day class, Fundamentals of Biological Dentistry. I still need to do this course too. So any of you guys interested, we can do this one together. There's a whole other side of this field called, like, with the airway side of things, which some of you may be exposed to. This organization is really good. I'm going to go to this conference next fall, 2025. So that's Ben Moralia and stuff. What's that?
This one sounds fun.
Yeah, Fort Lauderdale? Yeah. So there's a whole other side of this of how you can help, because, there's the whole like extraction orthodontics and where they, people had the case I did today, actually, the implant case I did before this meeting, the girl had premolars extracted and everything pulled back in ortho when she was in grade 7. How old was she? 24 or something, or 27? So now she's having all these sleep problems, TMD, all this stuff. So now she's going through expansion. They recreated the space for her premolars, and I did ceramic implants in the first premolars today. So there's the whole other side of this where with the airway side, and there's some, and especially with kids, there's some unbelievable things that can be done to help kids.
Worked with Dr. Mike to try and treat young kids.
Yeah.
And he's starting to.
Yeah. So Dr. Mike has begun taking courses in this area, and we're collaborating with a hygienist and myofunctional therapist, Alex Clinton, to help treat our patients, particularly our young patients with compromised airways. This is a very exciting area of dentistry to explore. And then I've created an action plan for us all to follow for those who are interested in joining me on this path. A good place to start would be learning more about ceramic implants and how to restore them so that you can have the knowledge to intelligently discuss these options with your patients. Listen to the podcast episodes I mentioned in this lecture. Check out the IAOMT website and read through some of their material. Consider attending one of the upcoming IAOMT conferences. And finally, come talk to me for more info on these topics, as there is a lot more I have to share. I want to sincerely thank you for your time and attention and for spending your evening with me. Any more questions or any discussion anyone would like to have? No? Well, thanks, everybody. Yeah. Well, we made it. All right.
I feel like people will have more questions, like as they're processing it, like on the drive home.
Yeah, I just
One of my suggestions is get your vitamin D tested, especially you suffer with COVID so long. I love to see your levels. Yeah, so next time you go for physical, you have to pay for it. It's $50. The doctor will do it unless you ask him for it. And they will say, you have to pay.